So what if I told you that getting a massive promotion at work or like finally moving to that exciting new city actually causes the exact same clinical brain drain as sustaining a major physical injury?
Yeah, I mean, it sounds wild when you say it out loud like that.
It really does. But welcome to today's deep dive, because if you're listening to this right now, you are stepping into a shortcut to understanding one of the most common yet, widely misunderstood human experiences.
Absolutely. We're talking about that overwhelming, almost suffocating feeling when your life just suddenly shifts gears.
Right. And today we're looking at two really fascinating sources to figure this out. First, we have these clinical diagnostic notes that detail a highly specific mental health condition.
Uh-huh.
And second, we are pairing that clinical data with the actual operational model of a Georgia-based telehealth practice called Coping and Healing Counseling, or CHC.
And our mission for this deep dive is to fundamentally validate those overwhelming feelings that accompany major life transitions for you.
Yeah, to show that you aren't crazy for feeling that way.
Exactly. We want to show you the clinical reality of what is actually happening in your mind and your body during those times. And then, we're going to explore how a highly specific type of brief therapy is designed to just resolve those feelings entirely.
Okay, let's unpack this because we really need to start by looking at how incredibly weird our societal expectations are regarding trauma.
Oh, they are so weird.
Right. Like, think about it. If you undergo a massive physical trauma, say, you get hit by a car and you break your leg, the path is perfectly clear to everyone around you.
Sure, you go to the hospital.
Exactly. You go to the hospital, your friends bring you casseroles, you get mandated time off work. The doctor literally points to an x-ray and says, look, there's the break.
Yeah, the expectation of your recovery is just universally understood.
Yeah.
The damage is visible, it's easily categorized, and it makes sense to people.
Right. There's a definitive before the accident and after the accident.
And nobody expects you to run a marathon while you're in a full leg cast.
Exactly. But then you look at massive life events. Say you experience a sudden job loss or like a brutal out of the blue romantic breakup.
Or relocating across the country.
Yeah, suddenly that x-ray machine just doesn't exist. There is this unspoken, incredibly pervasive societal rule that you should just walk it off.
Just bounce back.
Yes. Keep going to your meetings, keep smiling at the grocery store, just keep producing at the exact same level.
It is this expectation of seamless resilience.
Yeah.
And what's so troubling about that expectation is that it completely ignores the very real physiological and psychological toll that major transitions take on a human being.
Which is massive.
It is. We expect people to absorb massive shocks to their daily ecosystem without skipping a beat. But from a neurological and psychological standpoint, that is simply not how our brains are wired to function.
Which means we really need to start by giving this sense of overwhelm a proper name.
I agree.
Because if you're listening to this and feeling like you're drowning after a major life event, you have to understand that it is not a personal failure.
No, not at all.
It's not a lack of willpower, and it definitely doesn't mean you're broken. It is an actual recognized clinical condition.
It is. And it's called adjustment disorder. It's actually one of the absolute most common reasons people start therapy in the first place.
Wow, really? The most common?
One of them, yeah. Clinically speaking, adjustment disorder is defined as the development of emotional or behavioral symptoms within 3 months of an identifiable stressor.
Okay, so a 3-month window.
Right. So there's a clear, identifiable trigger in your life, and within 90 days of that event occurring, you just start exhibiting real distressing symptoms.
And when we look at those identifiable stressors in the clinical notes, I mean, the list is staggering. It covers the entire spectrum of the human experience.
It really does cover everything.
We're talking about job loss or a major career change. We're talking about a divorce or a painful breakup. It could be receiving a serious medical diagnosis like cancer or, discovering a chronic illness.
What's fascinating here is how the clinical criteria validates everyday struggles. Because the stressors don't even have to be universally negative events.
That is so true.
That's where a lot of people get tripped up.
Yes. The notes specifically mention things like geographic relocation, moving to a new city, retirement.
Becoming an empty nester when your kids finally leave for college.
Yeah, or having a new baby. I think most people expect to be absolutely thrilled about those milestones.
Right, because you wanted the baby, you wanted the promotion, you wanted to retire.
Exactly. Which probably makes the struggle feel even more isolating when you are suddenly failing to cope with a quote-unquote good thing.
It creates a profound cognitive dissonance. But you have to remember that the human brain, well, it craves homeostasis. It likes predictability,
So any major disruption is a threat.
pretty much. Any major disruption to your routine, even a positive one, requires a massive amount of cognitive energy to process. Suddenly, you don't know your new neighborhood, your daily schedule's entirely rewritten, maybe your support network is in a different time zone.
Oh, that makes sense.
Right. And the diagnostic criteria states that to be considered adjustment disorder, the distress you're feeling must be out of proportion to what would normally be expected from that stressor, or it has to significantly impair your functioning.
Let's focus on that phrase for a second. Significantly impair your functioning.
Yeah, that means the stressor is actively messing with your ability to perform at work or at school. It's damaging your social life and your relationships.
So it's not just feeling a little sad on a Sunday afternoon.
No, exactly. It is a functional impairment caused by an everyday life event.
You know, reading through this, the best way I can think to describe it is by looking at how our devices work.
Okay, I like a good tech analogy. Let's hear it.
So imagine you are going about your day. Your smartphone is at 100% battery, and you're handling your usual apps just fine, like work emails, family text threads, basic daily chores.
Mm-hmm.
Then you download a massive, unexpected new app. Let's call the app Sudden Divorce or Cross Country Move.
That is a very heavy app.
A ridiculously heavy app. It's poorly coded, it's constantly running in the background, it's pulling location data, syncing huge files, demanding constant attention.
Right.
Suddenly, your battery is draining rapidly. You're at 20% by noon. Your phone starts lagging. It freezes up when you try to open a simple email, and it just starts dropping calls.
That analogy gets right to the biological truth of what is happening. Because in that scenario, your phone isn't fundamentally broken. The hardware is totally fine.
Exactly. The phone isn't broken. It simply doesn't have the processing power like the RAM to handle that massive background application while also trying to run your normal daily life.
And that perfectly illustrates the core clinical concept here. Adjustment disorder is simply the gap between life's sudden demands and a person's current coping resources.
It's a coping gap.
It is fundamentally a coping gap, and that coping gap is exactly what we need to focus on next.
Because now that we've defined what the trigger is, that heavy background app, we need to explore how it actually manifests.
Right, because the anatomy of the struggle, the way this coping gap looks from the outside, is not identical for everyone.
Yeah, my phone lagging might look totally different than your phone overheating.
Yeah.
The clinical guidelines in our sources break adjustment disorder down into very specific subtypes based on what the dominant symptoms are.
They do.
So how does that breakdown actually work?
Well, the diagnosis specifies exactly how the brain is struggling to process the overload. First, you have adjustment disorder with depressed mood.
Okay, so that's pretty straightforward sadness.
Right. This is where the coping gap primarily manifests as tearfulness, profound feelings of hopelessness, and a total lack of pleasure in things the person usually enjoys. They might just want to sleep all day to escape the cognitive load.
Oh, wow. And then you have adjustment disorder with anxiety.
Yes, exactly.
How does the anxiety subtype differ in terms of how the person feels day to day compared to the depressed mood?
Think of it this way. If the depressed mood is a backward-looking sadness or a present stagnation, the anxiety subtype is an overwhelming forward-looking fear.
Oh, that's a great way to put it.
Yeah, it manifests as nervousness, constant worry, jitteriness, or even severe separation anxiety. The brain is frantically trying to predict the next threat.
Exhausting.
Truly. And of course, the third subtype is a combination of the two, officially called with mixed anxiety and depressed mood. You're experiencing the exhausting worries and the deep sadness simultaneously.
But it doesn't just stop at internal feelings, right? The notes branch out into behavioral symptoms, which I found totally fascinating. There's a subtype called with conduct disturbance.
Yes.
It sounds so formal and clinical, but reading through the criteria, I immediately thought of teenagers.
Conduct disturbance is a crucial subtype to understand, especially for parents. This is where the coping gap turns outward.
Meaning they act out.
Exactly.
Yeah.
The person starts acting out, violating the rights of others or violating major age-appropriate societal norms. You see this constantly when teenagers are struggling to adjust to a major transition, like their parents getting divorced or being forced to move to a new high school.
Right, because a 14-year-old might not have the emotional vocabulary or the self-awareness to sit down and say, "Mother, Father, I am experiencing profound internal instability due to your impending divorce."
Right, they're definitely not saying that.
Instead, they start skipping class, they get into fights, they break curfew.
Exactly. They're trying to exert control over their environment because they feel entirely out of control internally.
Hmm.
But from the outside, the parent or the teacher just sees a problem kid or a delinquent.
I just think it's bad behavior.
Right. They don't realize that the teenager's battery is completely drained by an invisible background app. There's also a mixed version of this with mixed disturbance of emotions and conduct, where they're experiencing the internal depression or anxiety while also acting out behaviorally.
Double whammy.
Yeah. And finally, the criteria includes an unspecified subtype for when the maladaptive reactions don't perfectly fit into those specific boxes, but are still clearly causing significant functional impairment.
Okay, I have to pause here and admit some genuine confusion on my part. As I was reading through the clinical timelines in our sources, the math didn't quite add up to me.
Oh, what do you mean?
Well, the notes state that an acute adjustment disorder lasts for under 6 months, but then it talks about a persistent or chronic adjustment disorder, which is when the symptoms last for 6 months or longer.
Yeah.
So I found myself thinking, wait, if it lasts longer than 6 months, shouldn't it just be considered major depression or a generalized anxiety disorder at that point? Why is it still just classified as an adjustment?
That is an incredibly perceptive question, and it's a distinction that trips up many people, honestly, even some clinicians. The crucial nuance here comes down to the root cause of the distress.
The root cause.
Right. So we have to differentiate between an internal chemical baseline shift like major depressive disorder and an external circumstantial overload. It remains classified as persistent adjustment disorder if the stressor itself or the direct consequences of that stressor are continuing.
Interesting. Can you give me an example of what a continuing stressor actually looks like in daily life?
Sure. Let's use the divorce example again. A divorce is rarely a single event that happens on a Tuesday afternoon and then is completely over.
Oh, absolutely not.
Right? It's a protracted, highly destabilizing process. It involves ongoing legal battles, tense custody mediations, selling a shared home, moving, and just a complete financial restructuring.
Which can take forever.
Exactly. That process can drag on for months or even years. Or think about caring for a terminally ill parent, or dealing with the fallout of a major bankruptcy that dictates your daily financial choices for an extended period.
So because the app is still actively running in the background and constantly updating with new stressful data, the adjustment period is just drawn out.
Precisely. You're still having an acute reaction, but you're having it to a chronic, ongoing situation. The diagnosis of persistent adjustment disorder acknowledges that the root cause of your depression or anxiety is still that specific external life event.
Rather than an internal generalized chemical imbalance. That makes total sense. It ties the reaction directly to the ongoing reality of the situation. So knowing the mechanics of this disorder, knowing that it's fundamentally a gap in coping skills tied to an external event, that naturally leads us to the question of treatment.
It does.
Because if this is a temporary gap in coping skills, it completely changes the therapeutic approach.
It implies that the fix doesn't require endless years of lying on a couch, analyzing your childhood dreams, or excavating deep-seated trauma from 20 years ago.
Which is a huge relief.
Oh, huge. Because this is a targeted circumstantial problem, it requires a targeted circumstantial solution.
Here's where it gets really interesting. The biggest takeaway from the clinical notes is this fundamental message. You do not need a big or severe lifelong diagnosis to deserve therapy.
No, you really don't.
You do not have to wait until you are completely non-functional or at absolute rock bottom to justify talking to a professional.
In fact, waiting until rock bottom makes the coping gap much harder to close. Adjustment disorder responds beautifully to brief, highly focused therapy. We are not talking about an open-ended, multi-year commitment here.
That's the best part.
Right. The clinical data shows that this condition often completely resolves in just 8 to 12 sessions.
I mean, 8 to 12 sessions is remarkably fast. I was looking at the specific evidence-based treatments listed in the notes, and cognitive behavioral therapy, or CBT, is heavily featured.
It's the gold standard for this.
I always assumed CBT was a heavy-duty intervention for severe depression. How does it work so effectively for a temporary coping gap? What is actually happening in the room during those 8 to 12 sessions?
Well, let's break down the mechanics of CBT in this specific context. CBT operates on the premise that our thoughts, our feelings, and our behaviors are all deeply interconnected.
Okay.
When that massive sudden job loss app is running, your brain automatically generates a cascade of catastrophic thoughts like, I will never find another job. I am a complete failure. I am going to lose my house.
And those automatic thoughts fuel the anxiety, which drains the battery even faster.
Exactly. It's a brutal negative feedback loop. In an 8 to 12 session CBT framework, the therapist isn't asking you about your relationship with your mother when you were 5. They're looking at that immediate feedback loop.
Oh, I see.
They teach you how to catch that specific catastrophic thought in real time. They ask you to examine the actual objective evidence for that thought and then actively reframe it. You are literally learning how to rewrite the code of that specific stressor app so it consumes less of your mental energy.
So it's intensely practical. The notes also mention problem-solving therapy. How does that differ from CBT?
Problem-solving therapy is even more direct and structural. It's really about breaking a massive crisis down into manageable, actionable mechanics.
Like project management for a crisis?
Well, essentially, yes.
Right.
Say the stressor is a new medical diagnosis. The overwhelm usually comes from feeling completely out of control. Problem-solving therapy teaches you how to systematically map out what you actually can control.
Like scheduling appointments, organizing your medication.
Communicating effectively with your family. Exactly.
Hmm.
And consciously, intentionally, letting go of what you cannot control. It breaks the overwhelming boulder into manageable pebbles.
That is brilliant.
And finally, the notes mention supportive therapy, which provides a structured, validating environment to simply process the emotional weight of the transition without judgment.
Going back to our tech analogy, the reason this brief model works so well is because you aren't trying to rewrite the phone's entire operating system.
Right, you don't need to.
You're just installing a highly specific battery management tool to handle that one heavy app. You are building a bridge over the current obstacle. And once you cross it, you have those skills in your back pocket for the next life transition.
It's about practical, immediate stabilization. But of course, knowing that a highly effective 8 to 12 session treatment exists is entirely useless if people cannot actually access it.
Oh, 100%.
Which brings us to the practical application of all these clinical concepts.
This is the major roadblock. Because if your brain is already maxing out its RAM, just trying to handle a divorce or a move, traditional therapy models ask you to commute 45 minutes across town, sit in a sterile waiting room with a bunch of strangers, and navigate a Byzantine insurance system.
It's exhausting just thinking about it.
Right. It's like asking a freezing, overheating computer to open 3 more heavy web browsers just to access the task manager. You're going to crash before you even get help.
Yeah, the traditional barriers to entry for mental health care can often exacerbate the exact overwhelm the person is trying to treat in the first place.
Which is why the sources use coping and healing counseling, or CHC, as a blueprint for how modern therapeutic infrastructure should actually work.
Yeah, they're based in Georgia, right?
They are a practice based in Georgia, yeah, but looking at their structural details, their operational model is a masterclass in removing those exact barriers. Let's look at why their model is so effective as a case study.
Well, the first and most vital component of their model is that they operate 100% via telehealth.
Which is huge.
It is. It's fully HIPAA compliant, ensuring total privacy. By entirely removing the physical commute, they immediately decrease the initial anxiety of seeking help. You can access the professional support you need right from your living room without adding another logistical hurdle to your day.
Like removing all the toll booths and traffic jams. And they serve a massive area. The notes highlight that they serve all 159 counties in Georgia.
Which is incredible when you consider how difficult it can be to access specialized care in rural areas.
Seriously. But what really stood out to me is their staffing model. The notes list this whole alphabet soup of credentials: LCSWs, LPCs, LMFTs. Why does it actually matter that a practice has all these different types of licensed professionals?
It matters immensely because of how differently the coping gap manifests in different people. Let's break down the acronym.
Please do.
So an LMFT is a licensed marriage and family therapist. Their entire clinical training is focused on family systems and relationship dynamics. So if your stressor is a divorce or a teenager with a conduct disturbance, an LMFT understands the intricate mechanics of that specific dynamic better than anyone.
Ah, whereas an LPC.
LPC, a licensed professional counselor, might be much better suited for an individual navigating severe career anxiety or the individual grief of a personal loss.
Oh, I see the distinction.
And then an LCSW, a licensed clinical social worker, is deeply trained in connecting people with broader community resources while providing therapy. CHC boasts a diverse, culturally competent team of over 15 of these professionals.
That is a big team.
It is, and that means they can actually match the specific software patch to the exact app that is crashing your system. They even offer life coaching for those who might just need structural guidance rather than clinical intervention.
It's a really comprehensive safety net. They see clients ages 13 and up, which is great. But we have to talk about the financial side. Because let's be honest, the absolute biggest barrier to mental health care is usually the cost.
Oh, undeniably.
Therapy is notoriously expensive.
Financial accessibility dictates clinical success. I mean, you cannot heal if you're constantly stressed about paying for the healing.
Exactly.
Our sources highlight how well-suited the brief therapy model is for modern workplace benefits, specifically time-limited EAPs or employee assistance programs.
I think so many people leave free therapy on the table because they just don't really understand what an EAP is or how it works.
Exactly. Many employers offer EAP benefits that include 6 to 10 entirely free, completely confidential therapy sessions.
Wait, 6 to 10 sessions?
Yes, and that is exactly the right amount of time to treat an adjustment disorder. You can literally use a standard work benefit to entirely resolve this clinical condition. They're also set up to take primary care referrals, meaning your family doctor can easily connect you to their network.
But the most striking data point in the CHC model to me is how they handle state and commercial insurance. If you have Medicaid in Georgia, CHC accepts it, and the copay is $0.
Wow.
Let me repeat that, $0. Furthermore, they accept major commercial insurance plans, Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. Depending on your specific plan, sessions range from just $0 to $40.
This is what structural accessibility truly looks like. Taking a condition that can derail a person's life and offering a scientifically proven brief treatment for as little as $0 without the patient ever having to leave their house.
While CHC specifically serves in the 159 counties of Georgia, their operational model is exactly what you should be looking for in your own state. Zero copay telehealth options, EAP integration, and short-term CBT.
Absolutely.
But if you are in Georgia and you're realizing right now that you are currently stuck in that coping gap, we want to make sure you have the exact blueprint to get out. You can reach them by phone at 404. Their website is cheattherapy.com, and you can email them directly at support@cheattherapy.com. Again, that is cheattherapy.com.
It's an incredible resource that directly addresses all the clinical realities and the access barriers we've been discussing today.
So what does this all mean? We have covered a massive amount of ground today, from the neurological mechanics of a life transition to the subtypes of a clinical diagnosis, all the way to the insurance billing of a telehealth practice.
We really have.
But circling back to our core mission, the ultimate message shining through all of our sources today is this. You do not have to wait until you are completely broken to ask for help.
Oh, please don't wait.
You don't need a severe, lifelong psychiatric diagnosis to deserve real evidence-based support. Life transitions, a new baby, a cross-country move, a lost job, a divorce, are a perfectly valid, clinically recognized reason to bring in an expert.
If we connect this to the bigger picture, it really demands a fundamental shift in how we view mental health care as a society. Seeking brief therapy for a life transition should not be viewed as an emergency intervention of last resort.
Right, like pulling a fire alarm.
Exactly. It should be viewed as routine, proactive health maintenance. When the demands of your life suddenly exceed your internal coping skills, you systematically build new ones. It is practical, it's highly effective, and thanks to modern telehealth models, it is more accessible than ever.
Which leaves us with a final thought for you to mull over. We started this deep dive by comparing the way society treats mental struggles to the way we treat massive physical trauma, like a broken leg.
Right.
But think about the minor injuries. Think about a sprained ankle from playing recreational basketball. When someone sprains an ankle, nobody tells them it is a personal failure.
Yeah, of course not.
Nobody tells them to just walk it off. We immediately send them to a few weeks of physical therapy so the joint heals correctly and doesn't turn into a permanent, lifelong limp.
That is a great point.
What if society started viewing the emotional sprains of life transitions exactly the same way? If we collectively recognized that a divorce or a career change simply requires a brief, targeted course of emotional physical therapy to heal properly, how much collective chronic human suffering could we completely prevent?
It would be world-changing, honestly.
It really would. Something to think about the next time life forces a massive, unexpected update on your system.